Okay. Yeah. Thank you. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you on behalf of Shield. Thank you very much for joining today's webinar, and I request all the participants to post their questions in the comment box given in the below. And good evening, Dr. Radhika Kandula, ma'am. Thank you for joining us today for the wonderful webinar, and it's an honor to introduce you, ma'am. So, Madam Dr. Radhika, ma'am, she is a founder at Institute of Women Health and Fertility, and she is a gynecologist and fertility specialist. And she, coming to education, she have completed her MBBS and DNB, FNB, and coming to postdoctoral training, she pursued a 2 year of postdoctoral fellowship in reproductive medicine from the National Board of Examinations under the guidance of Dr. B.N. Chakravarti uh, in IRM Kolkata, who is one of the pioneers in the field of infertility. And she has gained a vast experience in managing infertility and presented many papers at national and international conferences conducted by ICER, ASRM, ISHRE, and FOXY, and also co-authored several chapters in books related to infertility. She was a co-author and edited multiple chapters for clinics in reproductive medicine and assisted reproductive technology volume 2, as well as for the volume 1. And also she has co-authored and edited multiple chapters for reproductive technology volume 1. And also she was a co-author for a chapter stress and immune modulation in pregnancy and critical issues in ops and gynecology. And also she has co-authored for chapters in ovarian stimulation for intrauterine insemination and introduction, GnRH antagonist in intrauterine insemination, future challenges in intrauterine insemination in IUI JP Brothers book, as well as she got the accreditations in ICER and ISHRE. And coming to the professional recognition, honors, and publications, she was a faculty for ICER 2018 and a co-author for a research paper in ASRM 2011 and nominated for a scientific prize as well. And she also presented a poster presentation in ASRM 2011, and also she has given an oral presentation in ICER 2011 on outcome of antagonist IVF cycles following a day 3 and day 5 embryo transfers, and also another poster presentation in ISMAAR 2011, and also she has given poster presentation in a AGOI 17 annual conference November 2008, and also she has a second author in maternal and neonatal outcome in women at and above 30 years of age, presented at RCOG conference September 2008, Montreal, Canada. And also she has uh, given a presentation on second stage cesarean section in ARI-COG annual conference 2007. And also she has given one more presentation in Dakshin 2007 South Zone conference on maternal and neonatal outcome following second stage cesarean section. With this, thank you, ma'am, for joining us today. And before proceeding for the webinar, we have a short AV on Shield Connect launch, which is a digital platform. I request KVK to play the AV on Shield Connect. Oh, KVK, we can't hear the sound. Yeah, Shield Connect is a digital and dynamic platform to connect all the doctors at one place with the scientific literature and webinars and blogs. Shield Connect strives to improve the state of the patient care, adapting to the modern day practices and transforming the healthcare with science driven by innovation. I request all the delegates to please do look into the Shield Connect web page. You will find all the past webinars as well as upcoming webinars too. Yeah, with this, I hand over to Dr. Radhika Madam for the webinar. Thank you.
Yeah, thank you, Dr. Somesh, for that. Shall I start?
Yes, ma'am, you can start.
Yeah, a very good evening to all of you. I'm Dr. Radhika, an infertility consultant from Hyderabad. At the outset, I would like to thank Shield Healthcare for this educational initiative. I thank all my teachers for moderating me and molding me into what I am today. Today, I'll be talking about microbiome and human reproduction. Though the topic is quite boring, I shall try to make it as interesting as possible. So, what exactly is human microbiota? The collection of microbes living inside and on the surface of the human body are termed as human microbiota, whereas the collection of genomes of these microbiota are termed as microbiome. So with lot of literature, lot of studies going on, data had collected that presence of microbiome is established at every stage and every level of human reproductive tract, from vagina to ovary, that is vagina, cervix, uterus, fallopian tubes and ovary, to male reproductive tract as well, that is the testes and semen or spermatozoa. So both male and female reproductive tracts exhibit complexity and diversity in microbiota and making it difficult to understand this microbiota. So it's established that human microbiome affects all facets of reproduction, from gametogenesis, that is the male and female gametogenesis, to fertilization, the embryo migration into the uterus, implantation, and implications in the obstetric part, that is the early pregnancy failure, late pregnancy complications like preterm birth, late pregnancy losses, and postpartum endometritis and postpartum complications as well. So how did the scenario change? A few years back, we were not understanding all these things. We didn't know all these things, that there's so much of microbiota and microbiome going on. So how did the scenario change? So there are different methods to analyze microbiota. Earlier, we were using culture-based technologies. That is, we were using the 16S rRNA analysis of highly conserved genes and thereby finding out the microbiota. But with culture-based technologies, we cannot really identify many organisms, and it underestimates the diversity of ecosystem. So in fact, a recent study in surgical literature showed that more than 50% of dominant pathogens and 85% of major pathogens and wound infections cannot be identified by standard culture techniques. So what we have done now is, culture-based technologies are not done anymore. We are doing sequence-based technologies, where we are using 16S rRNA gene sequencing, especially the hypervariable regions within the gene are found out. So there are various techniques available in this metagenomics, like fingerprinting, DNA microarrays, targeted sequencing, whole genome sequencing, quantitative PCR, and next generation sequencing. So each method has different positives and negatives. Where DNA fingerprinting is relatively inexpensive, it lacks specificity. The targeted sequencing and microarrays are like it contains certain probes that target the specific species and genus of the microbiota. So it therefore gives the results very fast, and it has greater specificity and high resolution for a predetermined panel of microorganisms of interest. Next comes the whole genome sequencing. It allows a full discovery of the organism's genome, and it gives more information about the functional differences of the bacteria in a given community. But it is relatively expensive compared to other methods. Coming to the quantitative PCR, it's a technique most appropriate for low biomass specimens. That is, where the microbiota are in low abundance, we can detect it very early, thereby detecting the microbiota perturbations very early. The next generation sequencing, it's increased the resolution and accelerated the research, allowing full complex microbiota communities monitored. So NGS has given us an insight into vaginal microbiota in women suffering from idiopathic infertility. That is, once upon a time we thought that that was idiopathic infertility, is now found out that it is because of the vaginal dysbiosis or the endometrial dysbiosis that this lady is not able to conceive, or a patient is having recurrent implantation failures. Coming to vaginal microbiota, let's go specifically into vaginal microbiota. In normal vaginal flora, 90% are, that is predominantly lactobacillus, whereas 9% are bifidobacterium and less than 1% are conditionally pathogenic microorganisms like Gardnerella, Neisseria, Uroplasma, Candida, Mycoplasma, etc. In a healthy non-pregnant lady, vaginal microbiome is dominated by 4 lactobacillus species, which are more important, that is Crispatus, Iners, Jinseni, and Gasseri. Ravel et al. In 2012 had divided this vaginal microbial flora into 5 community state types, that is 1, 2, 3, 4, and 5, where 1, 2, 3, and 5 are lactobacillus dominant varieties. Community state type 4 are mainly anaerobic bacteria with reduced presence of lactobacilli. So what exactly these lactobacillus does is they produce hydrogen peroxide and also produces lactic acid, thereby decreasing the vaginal pH to less than 4.5 and helps to keep the vaginal pH below 4.5, thereby making the environment inhospitable for the pathogens to grow. So what exactly this lactobacillus does is, different strains have different immunological properties to have a role against protection against pathogens, and also they have altered gene expression, including defense against bacteriophages. These lactobacillus, as I mentioned, they produce lactic acid, and this lactic acid helps as a substrate for aerobic glycolysis, and this aerobic glycolysis provides energy for the growing blastocyst. And it also provides components necessary for cell membranes, nucleotides, and antioxidation. This lactate-rich environment is the one which is helpful in implantation, and also the lactate-rich microenvironment of the blastocyst helps in the local disruption of the endometrium, thereby helping in invasion and implantation. So whatever these bacteria, lactobacillus or the pathogenic bacteria that I mentioned, are not simply free-floating on the surface of the vagina, but then they form a 3-dimensional lattices or the biofilms over the inner and outer layers on the vaginal surface or the endometrial surface. They add on to the complexity of these vaginal and endometrial microbiota, and this allows a complex and dynamic interaction between the gamete, embryo, and the maternal tissue interface. So here you can see that these lactobacillus form a biofilm over the vaginal surface, And these lactobacilli produce metabolic products like lactic acid, hydrogen peroxide, acetate, other biosurfactants, are preventing the additions of this pathogenic bacteria on the vaginal surface. They also create, because of this physical interaction or the biofilm on the vaginal surface, they prevent the physical interaction of the pathogens onto the vaginal surface, and simultaneously they downregulate the genes responsible for adherence of these pathogenic bacteria on the vaginal surface and improve the immune host response. So here on the left-hand side, we can see that the infection caused a pathogenic bacteria to form a lattice or the biofilm on the vaginal surface. This is more important when we come to the treatment of these bacterial vaginosis or vaginal dysbiosis, where the antimicrobial treatment or the antifungal treatment that we give may not reach the vaginal surface completely because of the biofilm caused by these pathogenic bacteria. The picture below here shows the normal vagina on the left-hand side and bacterial vaginosis in the dysbiotic state on the right-hand side. Where normal vagina is predominantly lactobacillus, the lactobacillus is predominant in the normal vagina, producing lactic acid and the antimicrobial compounds, and also antimicrobial peptides and immunoglobulins, thereby creating a symbiotic community on the vaginal surface. Where in the presence of vaginal dysbiosis or bacterial vaginosis, there is disruption of the vaginal surface, that is the biofilm over the vaginal surface, and there is increase of the pro-inflammatory environment and pro-inflammatory cytokines, leading to more infection and more adherence of pathogens onto the vaginal surface. So there are many factors influencing the vaginal microbiota. Mostly endogenous factors are, most important thing is the age. In childhood and post-menopause, the estrogen levels and the glycogen levels are quite low, and the vaginal epithelium is quite thin. The lactobacillus species are less in abundance and the pH is quite high. Whereas in an adult woman, the estrogen and the glycogen levels are quite high. Vaginal epithelium is thick with high concentration of lactobacillus species, maintaining a low pH and acting as a protective barrier for infections to enter into the vaginal surface. In pregnancy, there is a decrement of vaginal pH and increment in the vaginal secretions because of the low concentration of mycoplasma and uroplasmas. The other factors that modify the vaginal microbiota are ethnicity of the individual, stress levels, smoking, obesity, conditions like carcinomas, infections. Presence of aerobic vaginitis or bacterial vaginosis can modify the presence of vaginal microbiota. In all these cases, it is seen that estrogen has a decisive effect on the composition of lower genital tract microbiota. So what happens in the presence of vaginal dysbiosis or bacterial vaginosis is, because of the disruption of the biofilm or the disruption of the barrier over the vaginal surface, these women are more susceptible to sexually transmitted infections, including HPV and HIV infections. There is an ascent of pathogens from the vagina into the reproductive tract, upper reproductive tract, that is to the fallopian tubes, and affecting the reproductive health. There is failure of embryo implantation because of the pro-inflammatory cytokines, following spontaneous conceptions or even following the ART procedures. There are more chances of recurrent pregnancy loss, preterm labors, recurrent implantation failures, all because of the pro-inflammatory cytokines. Urinary tract infections and yeast infections can cause reproductive tract damage, that is the tubal damage or pelvic inflammatory diseases, and resulting in infertility. So apart from bacterial vaginosis, there is another terminology called lactobacillosis, where the lady presents with similar complaints as in bacterial vaginosis, that is smelly vaginal discharge, burning and itching of the vagina. But here the vaginal pH is much below 4.5, and there in bacterial vaginosis, the vaginal pH is more than 4.5. That is, the vaginal pH is altered in bacterial vaginosis. So In such women, the pH of vaginal secretions play an important parameter. It's an important parameter for accurate diagnosis and in these women presenting with similar complaints. It is much less common vaginal condition where we have similar pH values but higher abundance of long segmented lactobacilli instead of the commensal lactobacilli which produce lactic acid and hydrogen peroxide. So there have been various studies which showed that vaginal microbiota has a relation on infertility. Bacterial vaginosis is pretty common, it's affecting up to 20 to 50% of women in the reproductive age, and it has an established risk factor for subfertility or infertility. The presence of specific bacteria which are abnormal or in presence of asymptomatic bacterial vaginosis with higher abundance of candida infection reduces the vaginal and cervical lactobacillus, and these women often present with fertility problems. The community state type 4, which are mainly anaerobic microbes, are more commonly associated with negative ART outcomes. Coming to the vaginal microbiota and its relation on the IVF outcomes, several studies have been done and confirmed that vaginal microbiota rich in lactobacillus without the presence of bacterial vaginosis, be it clinical or subclinical, leads to more positive outcomes with ART. Lactobacillus crispatus dominant microbiomes are associated with higher live birth rates, and they also have positive pregnancy outcomes by the end of pregnancy. There had been a prospective study done on reproductive age women undergoing IVF and found that embryo implantation was less successful in women with reduced lactobacillus species in their vaginal microbiota. So better knowledge of these vaginal microbiota prior to IVF may help both the couples and also the healthcare professionals to decide on the timing for their IVF cycles to maximize the results prior to entering into IVF treatments. There was a study done by Har et al. In 2016 where he included 84 women undergoing IVF, and he found that there's a strong relationship between microbiota composition and pregnancy. 22 women had altered composition, out of which only 9%, that is only 2 women, achieved a clinical pregnancy. Whereas women with normal microbiota, there are 62 women and 47% successfully achieved a clinical pregnancy out of these 62 women. So this is another cross-sectional study done by Babu et al. They have done a study on healthy women and women with infertility problems with no symptoms of bacterial vaginosis. In fact, they have suggested that adding a routine vaginal microbiota screening for all these women undergoing infertility treatment would give us a better reproductive outcome instead of going ahead and doing the treatment and then having a failure of infertility treatment. But then the study is quite small. Because of the small sample study, the evidence is too limited to recommend a routine screening of all fertility patients. Moreover, the molecular diagnostic testing that we are implementing is quite extensive, and there is no literature supporting to recommend diagnostic modalities or screening modalities in asymptomatic women. Coming to the diagnosis, how do we reach a diagnosis of vaginal dysbiosis or bacterial vaginosis is, first and foremost thing is clinical symptoms of the lady, that is a malodorous vaginal discharge with itching and burning sensation remains the main clinical suspicion. And for women with suspicion or symptoms suggestive of dysbiosis, they should be taken up for speculum examination and taken up for pH test to differentiate between bacterial vaginosis and lactobacillosis. There have been several techniques that were developed to evaluate and confirm the diagnosis of bacterial vaginosis, like Ansel criteria, Nugent scoring, and more recently, quantitative polymerase chain reaction. Ansel criteria and Nugent scoring are reasonably inexpensive, but the outcome of these results, that is the precision accuracy, is quite low. The Ansel criteria were postulated in 1983 where bacterial vaginosis diagnosis was confirmed when 3 out of 4 symptoms were positive. That is, thin grayish vaginal homogeneous discharge, pH of more than 4.5, production of fishy odor on addition of 10% KOH on vaginal discharge, or demonstration of clue cells in wet mount microscopy. 3 out of these positive 4 symptoms would be confirming the diagnosis of bacterial vaginosis. But the precision is quite low, and only 40% of women diagnosed with bacterial vaginosis were found to have positive findings in AMSEL criteria. Coming to the Nugent scoring system, it was postulated in 1991, where the bacterial strains were assessed by gram staining and the scoring was given from 0 to 10, and the women were classified to be normal when the scoring was 0 to 4, intermediate with small gram-positive variable rods when the scoring was 4 to 6, and bacterial vaginosis was confirmed when the scoring was 7 to 10. So as mentioned, AMSEL criteria and Nugent scoring, though reasonably inexpensive, the accuracy is quite low. Recently, a multiplex real-time PCR assay, which is a novel diagnostic tool which has high specificity and excellent sensitivity to simultaneously detect Neisseria gonorrhoeae, Chlamydia trachomatis, Mycoplasma, and Trichomonas, had been postulated, and it's supposed to be having high specificity and sensitivity. Once the lady is diagnosed to have bacterial vaginosis, antibiotics and antifungals remain the mainstay of treatment. Though the recurrence rate is quite high and there are a few side effects associated with these antimicrobial therapy, they remain the mainstay still. As per the CDC guidelines, the treatment for bacterial vaginosis is metronidazole 500 mg orally twice a day for 7 days, or the use of metronidazole or clindamycin gel once a day at bedtime for 5 to 7 days. The alternative treatments include tinidazole, clindamycin orally, or clindamycin ovules for 2 to 7 days. In pregnancy, the recommended regimes are metronidazole or tinidazole 2 grams orally once a day for 2 days. Alternatively, metronidazole can be given in divided doses of 500 mg twice a day for 7 days. Tinidazole is reasonably longer acting and it's now become generic and cost effective, but the use of tinidazole in pregnancy is still limited. The studies are still limited for regular use of tinidazole in pregnancy. Even after complete treatment of bacterial vaginosis with the antimicrobial therapy, the recurrence rate after 1 month of therapy is as high as 20 to 40% after 1 month. So this recurrence may be because of the persistence of bacterial vaginosis associated organisms or a failure of lactobacillus flora to recolonize on the vaginal surface. So in such cases, twice weekly metronidazole gel for 6 months may reduce the chances of recurrence. So the key points for treatment of recurrence is we have to understand that the recurrence is very common and we have to even counsel the patients about the recurrence chances. So treatment attempts should be directed to treat the pathogens, decrease the anaerobes, and to allow the commensal lactobacilli to repopulate. Plummer et al. Has demonstrated that antimicrobial drug treatment in male partners simultaneously would exert beneficial effects and thereby decreasing the chances of recurrence in such women. Probiotics or the targeted probiotics may be used to replenish the depleted microbiota, which are commensal type, to restore healthy conditions and consequently treat infections and illnesses in women with bacterial vaginosis. They can be used in adjunction to antibiotics to restore the commensal microflora. So these probiotics are nothing but live microorganisms which, when administered in adequate amounts, confer a health benefit on the host. So what is more important is to use the right lactobacilli for treatment. That is, the lactobacilli which produce hydrogen peroxide or the lactic acid, which are more important in treatment of replacement of commensal bacteria on the vaginal surface. This is the evidence showing that treatment of vaginosis has reasonably improved the reproductive health of these women and can eliminate the antiviral effect, reducing the microbial load and improving the chances of pregnancy or fertility in such women. It is established that treating bacterial vaginosis can increase the pregnancy to as high as doubling the pregnancy rate. So the routine recommendations for clinical practice now are, it is a good recommendation to screen all the women or to ask all the women of the clinical symptoms like smelly vaginal discharge, symptoms of vaginal infections or urinary tract infections, symptoms suggestive of candidal infections, then itching, burning, currently or during the cycle. So the main clinical suspicion would be because of the symptoms given by the lady. Whereas women with no symptoms, as of now, asymptomatic women has no current recommendation to test further or treat further in these asymptomatic women. As I already mentioned, not only the vagina, even the upper reproductive system is supposed to be having these microbiota from cervix, uterus, fallopian tubes, and even the ovaries. So once upon a time, this upper reproductive tract was thought to be sterile. But discovery of specific and independent endometrial microbiome, because of several studies, has shown that there is endometrial dysbiosis specifically and independent of vaginal dysbiosis. So this endometrial dysbiosis can cause an implantation failure and may lead to infertility because of this disturbance of commensal bacteria and the host immune response. Because the infertility treatment is intrinsically complicated and the results mainly are dependent on the implantation phase, so modifying the implantation phase and improving the implantation by correcting the endometrial dysbiosis may result in positive outcomes. Moreno et al. In 2016 had shown that a lactobacillus dominant endometrium is more receptive to pregnancy or more receptive to the embryo than endometrium of women with high bacterial diversity and a low proportion of lactobacilli. He'd shown that there is a higher chance of implantation, higher chance of pregnancy and live birth rate in these women and a significantly lower miscarriage rate. Where a contemporary study done by Franzek et al. Showed that there is a comparable IVF success rate independent of this lactobacillus dominance of these endometrial microbiota. But then they have suggested that the difference could be related to the difference in the classification system done by both these studies. So this image shows that lactobacillus dominant microbiota in the endometrium or the vagina has resulted in better outcome following IVF, and a presence of anaerobic bacteria and low abundance of lactobacillus, high concentration of Gardnerella and Etopobium vagina has resulted in lower implantation rate, increased number of miscarriages, decreased number of term pregnancies and live birth rates, and decrease in the spontaneous pregnancy rates as well. Where there is a disruption of the peaceful coexistence of microorganisms with the host immune system in the endometrium, there is a condition called chronic endometritis. Fortunately or unfortunately, these women have no noticeable signs or they have very mild symptoms. That is why they are missed out on normal clinical examinations or history taking. The prevalence rate is as high as 10%. The role of chronic endometritis in fertility had been underestimated till now because of the asymptomatic status of the women. But now, because of the study of these microbiota, it is now recognized as a possible cause of not only infertility but also recurrent implantation failures and early miscarriage because of the non-receptive endometrium, which is the main reason behind poor obstetric outcome or a reproductive outcome. Like this chronic endometritis is known to cause decreased spontaneous conception rates, they lower the implantation rate and cause recurrent implantation failure because of the pro-inflammatory cytokines and also result in poor obstetric outcomes like recurrent pregnancy loss, intrauterine infections, preterm deliveries and postpartum endometritis. So, how do we diagnose this chronic endometritis women? Because they're reasonably asymptomatic or very mild symptoms are there, they're in women with recurrent implantation failures or recurrent pregnancy losses, it's always advisable to go in for chronic endometritis screening. The suspicion can be given by ultrasound or chronic color Doppler findings like thick endometrium, which is hyperechoic and difficult to differentiate the endometrium and the myometrial interface, and the fluid hysteroscopy showing diffuse and focal hyperemia with strawberry pattern of appearance. Quantitative PCR or next generation sequencing of 16S RNA gene in the endometrial sample is highly sensitive in picking up the cases of chronic endometritis. Immunohistological staining has a sensitivity of 58% in picking up these plasma cell specific surface antigens. MRI also helps in the diagnosis of chronic endometritis. Once confirmed, these women have to be treated with capsule doxycycline 100 mg twice a day for 14 days, and this confers a cure rate of almost 96%. Alternative treatment is ornidazole 400 mg twice daily, along with metronidazole 500 mg twice daily for 14 days. This also confers a reasonable cure rate of 73%. In cases of persistent infection, that is, persistent infection despite the antimicrobial therapy, the same regime can be repeated up to 3 times. So, the efficacy of antibiotic therapy in treating women with certified chronic endometritis and recurrent implantation failure has been now established, and it is shown to improve the uterine receptivity. Although there is no data as of now for the routine use of probiotics in chronic endometritis currently, because of endometrial dysbiosis and the studies on microbiota, they seem to offer a promising approach and may require further study to see that probiotics may help us to improve the endometrial dysbiosis or chronic endometritis cases. This is a study done by Seminal et al. In 2015, where they have shown that after antimicrobial therapy in chronic endometritis, women with no infection or suppressed infection have shown to have improved implantation rate, clinical pregnancy rate, and live birth rate in comparison to women with persistent infection even after this antimicrobial therapy. So, as we know that this antimicrobial therapy is quite good in treating vaginal dysbiosis and endometrial dysbiosis, does it mean that we use antibiotics as a routine to change the vaginal typology or the endometrial typology? No. The efficacy of using antibiotics in conjunction with IVF treatment as a routine is still not established, and in fact, ASRM strongly recommends against the use of these antibiotics prior to embryo transfer. In fact, the use of these antibiotics prior to embryo transfer could impact the normal healthy colonization of the endometrium and reduce the efficacy of this procedure. Perhaps we need to be doing this next generation sequencing and picking up the women who are having vaginal and endometrial dysbiosis in future to improve the endometrial, the timing for embryo transfer, and prognostically counsel these couples so that they have a good reproductive success or reproductive outcome following the embryo transfer. So, as I said that the vaginal microbiota and the endometrial microbiota changes reasonably because of the exogenous factors like stress, obesity, improper dietary habits, and smoking. So, preconceptional counseling is very, very important in these women. Diet, stress, smoking, overweight, obesity, all these conditions are supposed to be resulting in higher Nugent score and more chances of bacterial vaginosis in these women, thereby decreasing the chances of having a good reproductive outcome or a good pregnancy outcome. So, preconceptional counseling is useful and can impact the reproductive outcomes, possibly by modulation of these vaginal microbiota. Weight loss, regular physical activity, abstaining from smoking, and active lifestyle changes should be discussed and encouraged in all these women. After discussing the microbiota of the reproductive system in female, let's have a word about seminal microbiota. These seminal microbiota not only play a role in maintenance of men's reproductive health, but may also be related to the health of the couples of these offspring through the transfer of couples and the offspring through the transfer of these microorganisms. Alteration of the seminal microbiome are known to be associated with sperm factors like altered motility and increase in the sperm DNA fragmentation. This motility effect and the DNA fragmentation may be because of the direct interaction of microbes with the spermatozoa, thereby addition to these cells and releasing soluble factors, decreasing the sperm motility and promoting the apoptosis, or it can be toxic effect mediated by the inflammatory cytokines, increasing the release of reactive oxygen species and decreasing the motility of these sperms and worsening the DNA fragmentation. It is shown that lactobacillus is predominant in good quality sperms, whereas low quality semen and azoospermic semen are shown to have predominance of anaerobic bacteria and pathogenic bacteria and decrease in the composition of lactobacillus. It has been seen that probiotics and the prebiotics have been shown to ameliorate the semen parameters and in both the animal models and human models. There have been various studies to suggest that 6 months to 6 weeks therapy, 6 weeks to 6 months therapy of male partner with lactobacillus and bifidobacterium have been shown to improve the sperm motility and decrease the percentage of sperm DNA fragmentation and reduce the rate of atypical forms and improve pregnancy rate in actinozoospermic males. So to conclude, with the advancements in sequencing and metagenomics, we have better understood the reproductive microbiome, and we have seen that the microbiome affects the reproductive potential at various stages. Though the study sample size was quite small, further research with larger sample size may be required to confirm the impact of microbiota and microbiome on reproductive failure and success. What is more important is the subtle changes in the microbiome or the vaginal and endometrial dysbiosis, which have a meaningful change which may be associated with meaningful change in gamete quality and ultimately improve the clinical outcomes following treatment. Maybe the better understanding of this microbiota may one day lead to the ability to manipulate this microenvironment and improve the successes in outcomes of reproductive treatment. As I said, preconceptional counseling plays a very important role in improving the reproductive outcome. The antimicrobial usage has a clear benefit in women with bacterial vaginosis and chronic endometritis. In asymptomatic women with history of recurrent implantation failure and recurrent pregnancy loss, antimicrobial therapy has played a role. Replacing the pathogenic microbiota with the beneficial ones by use of probiotics may be a way to positively affect the reproductive outcomes in women with vaginal or endometrial dysbiosis. Due to the advances in microbiome research, apart from infertility, scientists have also obtained an insight into many complex disorders like obesity, carcinoma, and inflammatory bowel disorders. Thank you all for the patient hearing. Thank you. I end my talk here.
Thank you, ma'am. It was actually a very great presentation. It's always an honor and a learning to hear you, ma'am.
Yeah, thank you so
Ma'am,
much.
if you allow, then we will have a question and answer session. I'll
Yeah,
read the
that's fine.
questions from the delegates.
Yeah, sure.
Okay, ma'am. Ma'am, we have a first question. That is whether patients with varicocele linked with any differences in seminal microbiome.
So vaginal varicocele itself is not associated with any change in the vaginal seminal microbiome. Sorry. So seminal microbiome or the dysbiosis are mainly because of the pathogens. Varicocele has no pathogenic appearance there.
Okay, ma'am. Thank you. And we have Dr. Ramadevi K saying that it's a useful presentation.
Yeah, thank you.
And we have one more question, ma'am. Can we do transvaginal microbiome implantation during the IVF treatments?
Like in the case of asymptomatic women or symptomatic women?
I mean, they didn't say, ma'am. Just they said that whether we can.
There is no role of prior treatments in asymptomatic women prior to embryo transfers. In fact, it's been against the embryo transfer to change the vaginal typology to improve the with an anticipation to improve the outcome of pregnancy treatments. There is no role of treating prior to embryo transfer. No, we cannot do that.
Thank you, ma'am. And we have one more question, that is uh, assessing active follicular microbiome is significant compared to assessing the vaginal and uterine microbiome.
Probably that makes more sense, but then follicular microbiome, there is no role of, routinely screening for follicular or uterine microbiome or cervical microbiome for that matter in asymptomatic women. Where the women are more symptomatic, like, because follicular microbiome really would not give us any more symptoms until unless they have infections in the form of, tubal infection or tubal damage suggestions. We do not have any suggestions or any symptoms suggestive of these infections. Whereas in cervical, vaginal or endometrial microbiome or dysbiosis, the lady presents with symptoms, and thereby we can screen these women and go ahead and have a healthy vaginal or cervical or endometrial environment prior to the ART treatment.
Thank you, ma'am. We have one more question. Whether microbiome really affects the prematurity?
Yes, in presence of bacterial vaginosis and endometrial dysbiosis, it has been there have been studies to show that preterm labors are higher in cases of bacterial vaginosis and also endometrial dysbiosis. It's been an established cause for that.
Thank you, ma'am. We have one more question. What is the threshold for doing molecular testing?
Basically, molecular testing is quite expensive. So in a lady with symptomatic bacterial vaginosis or symptomatic chronic endometritis, or there is a strong suspicion of chronic endometritis, or women with recurrent implantation failures, despite so many treatments, there had been a recurrent implantation failure and recurrent pregnancy losses. So it's always advisable to go ahead and have a molecular testing in these women.
Thank you, ma'am.
Yeah.
Ma'am, I don't find any additional questions in the comment box. So if you allow me, then we will close this webinar.
Yeah, thank you.
Yeah, thank you, ma'am. Thank you
Thank you all.
for the wonderful presentation.
Thanks a lot. Thank you. Thank you all for the patient hearing. Thank you.
Yeah, thank you, ma'am. And also, I thank all the delegates for participating in this webinar. Yeah, many thanks from the Shield team.